Oh, good morning. Thank you very much. Thank you, Thoraya. Thank you to the organizers. This is a wonderful meeting, and I'm so happy to be here to talk with you. Here we go. So I'm going to talk a little about following Eric's theme and really talk about assessment and try to talk about the past, the present, and also where we might be going in the future. I'm going to spend a little time talking about professional self-regulation and the importance of assessment. You know, hearing about all of the wonderful transformative things that are going on in medical education and training is certainly where we should be headed, but it makes me more concerned about having appropriate assessment activities so that we can actually determine, as you heard earlier today, that the physicians that are graduating out of these programs and crossing boundaries are competent to practice. We'll talk a little about what is our obligation to our patients and the public. You know, I think that patients and the public actually expect that somebody is assessing the physicians that are working in their systems. You know, whether it's the hospitals that are employing them, or even that health officer that was doing surgery in Africa, my guess is that the patient that was undergoing that procedure had some expectation that somebody or some organization was certifying that they were actually practicing to a standard, that there was a standard and they were practicing to the standard. We also have an obligation to each other. You know, we work as colleagues, and you don't want to have to take 3 to 6 months of working together to get a sense of your colleagues' competence. But even more important, we actually have an obligation to our students. You know, we have an obligation to those that we're training to understand that there are standards of care. There are standards of care for specialties, and that it's part of professionalism and professional self-regulation to continue lifelong learning so that you can practice to that standard. So we'll talk a little about physician assessment today and where we might be going tomorrow. But I have Dr. Souza's quote here, is how do I choose the healthcare provider for the ones I love? You know, I think each one of us in this room knows how to answer the question to one of our family members if they say, I have a friend or I have a problem, who should I see? You know, and we know who those people are. And the rest of the world, all of our patients should actually have that same ability. So that's my conversation today. I'll talk a little about, so I work for the American Board of Medical Specialties. ABMS is a federation. It's a federation of 24 independent member boards, and we certify, our member boards certify physicians in 37 specialties and 123 subspecialties. More than 800,000 physicians in the United States currently are ABMS member board certified. Approximately 17% of the physicians practicing in the United States are not board certified. And our boards are made up of more than 5,000 physician volunteers. There's also substantial public membership, both on the ABMS boards and also our boards. And our boards, our specialty boards, develop the standards of care for the specialty that inform the program requirements for ACGME, and board certification serves as a key outcome measure of graduate medical education in the United States. So even though in the United States, graduate medical education and the certifying boards are separate organizations, we are kind of joined at the hip, loosely, because our board standards inform the training, and our board certification is an outcome of that training. But board certification in the United States, even more, is a quality indicator. It's a quality indicator to patients, families, and healthcare systems that physicians have been vetted and that they are actually performing to a standard. These are our 24 member boards. Our boards range in age from 100 years. The American Board of Ophthalmology was our first board, just celebrated its 100th birthday, to as young as one of my boards, medical genetics, which is a little over 25 years old. Our boards also range in size. Internal medicine is over 200,000 diplomates. They are 1/4 of all board certified physicians in the United States. And when internal medicine makes a move, the rest of the boards feel that. Some of our boards are quite small. Colorectal surgery and genetics have about a few thousand diplomates each. So that explains some of the variability. But the boards all are independent, and they certify physicians independently. Where they come together is under the ABMS umbrella. And as part of the ABMS, they have agreed to standards of certification and also standards of maintenance of certification. Board certification is core to professional self-regulation. The primary commitment behind professional self-regulation is to the public, to patients, families, communities, and others that rely on their credential. Our boards and ABMS are public-facing. We're not membership organizations. We don't work for healthcare organizations. We don't have any implicit bias in this. We're probably the only people that are non-conflicted in assessing physicians. Board certification is of the profession and by the profession. And what I mean by that is it actually grew out of the profession. The American Board of Ophthalmology was first formed, it's our oldest board, 100 years ago because there were people who were calling themselves ophthalmologists that were blinding people. And there was a recognition at the time that there had to be standards of care. And so that started the board movement. But they're also by the profession. The boards are made up of physicians of that specialty, and they develop the standards of care. Certification requires and supports both high-quality medical education. We are joined at the hip with the medical education community. And it also utilizes and incorporates information from high-quality, meaningful, and relevant assessment methods. But understanding global differences in medical practices, resources, and culture are also the key. And I'll talk a little about the differences that we've seen in helping develop certification exams outside the United States. So in the US, there's initial board certification and then something called continuing certification that I'll talk about. The one thing I learned since coming to ABMS is that board certification is not just an exam. It's actually a process, and it's important to understand that process. It's a process that begins with an evaluation of professionalism, completion of training in an ACGME accredited residency program or fellowship, and understanding the training program and how residents and fellows are assessed there is the key. Because our boards really rely on the training program directors and the faculty to assess the fellows and the residents in the training program, and that is especially important for the non-knowledge-based competencies. All of the assessment for communication, systems-based training, professionalism, practice-based learning is really done in the training program. That culminates with a statement by the program director that the physician can practice independently and without supervision, and then is eligible for certification. The physicians take a certifying exam, and some of our boards give oral exams, and then if they are successful, they can call themselves board certified specialists. We also have a relationship with the Ministry of Health in Singapore. And I'll talk about this for a minute just to talk a little about the differences that we've learned in helping create exams. So in 2009, Singapore identified ABMS as a potential partner to strengthen Singapore's system of assessments, and specifically to complement the newly implemented ACGME residency training program. Dr. Hawkins, who's here, was actually very instrumental in helping set this up for ABMS at the time. The ABMS Singapore collaboration was formalized in 2012, at which time the development of 12 specialty exams were phased in over a 4-year period. What we learned at that time was that the certifying examinations really have to be contextualized to local practice, to training and local practice in Singapore. And so what was developed was a partnership between our certifying boards in the United States and subject matter experts in Singapore to not only train people in Singapore to develop and write certifying exams, but it's a partnership that extends from blueprinting to item writing to standard setting. The exams are tailored to local needs rather than wholly importing US content. And it's really important. Some people say, well, why can't we just take the US exams? But the reality is that it really has to be tailored to practice and training locally. And it comes down to the item level, because even the description of the patient is different. I had an interesting conversation when I was in Singapore talking to some orthopedic residents. Well, orthopedic residents in Singapore are like orthopedic residents everywhere else in the world. They have about 17-inch necks. They all look like they've been athletes before. And they're usually, in great fun. And so they take the in-training exam from the U.S. as part of their training. And so I said, well, what'd you think of your in-training exams? And they all started laughing. And I said, I usually don't hear people laugh about in-training exams. And they said the description of the patients is a bit difficult, because many of the orthopedic in-training exams start with, Joe was playing quarterback and he was sacked, and all of a sudden he had a problem, and there were all these sports analogies that just didn't make sense. So what our staff at ABMS does with individuals from the Ministry of Health in Singapore, local subject matter experts, and also subject matter experts from our boards is, as Krista Albee, my vice president, says, kick the tires on every item. They literally look at every item to make sure that the examinee is going to understand it. So presently in Singapore, 2016 marks the year in which all specialties within the collaboration are getting examinations, and that's been phased in over 4 years. So it's really been very successful, and it's been an example of a really good partnership between the Ministry of Health in Singapore and ABMS. But what occurs after the handoff from graduate medical education and initial certification, and how do we account for multiple changes in practice over time? And this is something that is very challenging that we're grappling with at this point. Because clearly if I'm board certified in pediatrics and medical genetics, so I'll just use me as an example. When I graduated and was certified in one of those, I was ready to practice in the broad specialty. But 35 years later, my specialty has narrowed over time. And how do you continually reassess people during that time period? When board certification started in the United States, people were just given, it was a diploma. They were board certified, and they never had to be assessed after that. And that actually didn't make sense. And the reason it didn't make sense is this. If you look at medical school, every so often the LCME looks at its standards and redoes them. In GME, the ACGME residency review committees are reviewing the program requirements, every 10 years or so. And then we graduate people and we launch them into practice, and they practice for 35 to 45 years these days, and they never get reassessed. And when you look at what has happened over the last 10 to 25 years of medical practice, medical knowledge just continues to increase. I'm a geneticist. The first year I started my training, this new technique called PCR was developed. And look at what has happened just in my small specialty. So the boards actually went from time unlimited certification to TenYear certification, and now to something called the ABMS Program for Maintenance of Certification. And in order to participate in MOC, you must have achieved initial board certification. It's based on the 6 ABMS ACGME core competencies that we heard about earlier from Eric. And there are 4 integrated elements. And those elements are professionalism and professional standing, lifelong learning and self-assessment, that's generally accredited CME. The assessment of knowledge, judgment, and skills, this is currently being assessed by a 10-year high-stakes secure exam in each of the specialties, and improvement in medical practice. Because we feel that it's part of professionalism and professional self-regulation for a physician to be involved in improving his or her practice over time. So that has to be part of what is said about a physician in practice. But, and I'm sorry this is so small, but how can we best assess physicians during the course of their careers? And this is actually a figure from Cruz and Cruz published this this year. It's their re-envisioning of Miller's pyramid. And the difference is there's this is at the top. If you look at here, and what it's a physician's professional identity. And to me, that's the thing each one of us knows about a physician when we recommend him or her to our mother, to our child, or to our next door neighbor. And it has more, what the essence of that is more than medical knowledge. And I think that a lot of that is really the assessment of the non-knowledge-based competencies. How professional they are, how they communicate with patients, how they care for their patients, and how they're involved in practice-based learning and development, and what their dedication is to lifelong learning. The challenge is we don't really have good assessment activities for assessing those competencies. For initial certification, the assessment of those competencies is delegated to the program director. They're delegated to the program director and the training program faculty who have eyes on the target. They can tell. But if you go into 45 years of practice, who assesses you? How can you be assessed in those competencies in a decent way for people to make certification decisions on? So many of our boards are starting to do pilots to try to see how we can do things differently. The TenYear secure exam, if any of you have been following the maintenance of certification discussion in the United States, you'll find that it is quite active. And there are quite a few physicians who don't feel that it's relevant to their practice. And part of this is the fact that when you're examined every 10 years on the broad knowledge of the specialty, it's not quite relevant to physicians who have focused their practices in very, very small areas of the specialty. So the American Board of Anesthesia, one of our boards, has developed something called MOCA Minute, MOC Anesthesia Minute, and instead of what they're piloting is that instead of a 10-year exam, what their diplomates will get is a question, 20 questions a quarter. And the question looks like this. This started off as a weekly question, but they're going to quarterly questions. So you get an email that says, here's your MOCA Minute question. There's your question. You answer the question, and immediately you get the right answer. So you have the ability to answer the question, but then you get your formative feedback. Now, how is this an assessment and not just a self-assessment learning activity? Well, the way that the system is actually developed, and it can be delivered on a mobile device, or you could do it on a web browser, is that the algorithms are written so that if you get that question wrong, a clone of the question gets sent to you in the future. So instead of the board assessing knowledge on the basis of 150 questions every 10 years, they can actually do longitudinal assessment so that they're actually assessing people in real time over 800 data points over that 10-year period. So the key elements of the system, it's longitudinal assessment with spaced repetition, consistent with adult learning theory. It can be practice relevant. So a physician can go in and put in what their area of practice is. So I'm a geneticist. When I practiced at Children's Hospital in Boston, I only did pediatric genetics. So what my board can do is send me questions that have to do with pediatric genetics, but also then many of the questions that are core to the specialty, so that if I still have a certificate that says medical genetics, I can say that I was evaluated in that. But then if I go to Oklahoma 3 years later and I have to do cancer in adults and prenatal, I can actually change that. Just-in-time information can be sent in this way. So several months ago, when the Zika virus hit the States, anesthesia sent out an item on Zika virus. It was in the form of an item, and it was actually connected with the CDC guidelines on Zika. So it's a great way to deploy things. Gives you immediate feedback. The diplomates get a dashboard. There is an ability to make efficient summative decisions with information aggregated over time, and it identifies gaps that can facilitate learning. So anesthesia is doing this. This is probably the newest thing that's come through. Anesthesia is doing this as a pilot that may eventually replace the TenYear exam. ABMS has invested in development of a platform because we have 7 to 10 other boards who are interested in doing this. So we as an organization have invested in the development of the platform that the boards can use who are interested in doing this. So we may actually have a change in the Part 3, the exam. So what else could the future bring? Maybe continuing certification in the future would be a portfolio of assessments that are both board-based, like the external assessment of knowledge, but also board-recognized, contain an appropriate balance of requirements for both the broad specialty and the focused areas of practice, but still allow for a summative decision to be made over time, which is the important piece of this and how it makes assessment really different than learning. And maybe that portfolio could include simulation, practice data, surgical privileges. You know, if a surgeon loses their privileges, that's something that's important in evaluation of that surgeon. 360 evaluations. I was a training program director. My residents, you know, if I did 360s and the patients filled them out, the other attendings filled them out, and the nurses filled them out, they were stellar. But, you know, there were a few that if you gave that 360 to the secretary in the clinic area, that's where the unprofessionalism came out. So you do enough 360s, you actually will find the problems. Registry and outcome data. You know, when maintenance of certification started 10 years ago, 10, 15 years ago, hospitals and healthcare systems were not developing metrics. They weren't measuring things, but now hospital and healthcare systems are. And so how can that be incorporated into this? State licensure data, whether or not a doctor loses their controlled substance license. It's important. Continuing medical education, data derived from departmental reviews, and for global physicians involved in global health, cultural competence data. You know, as people travel from one culture to the other, there needs to be, they need to understand how to practice medicine within that system. So to close, and this is just a quote from Kees van der Vleuten, who many of you know, any single assessment is but one data point. Each assessment should be optimized for learning, and it takes a lot of data points to get the full picture. So perhaps 5-10 years from now, maintenance of certification or continuing certification will be a collection of important information about physician practice, knowledge, and the competencies that tell a story. That tell a story about that physician as they go through their professional life that actually will allow patients to make the same decisions that we do in referring patients, our family members, to physicians. Thank you.